Thanks for allowing me to share a little bit of data on CAR T. Hopefully this will do what it should do, and I believe it will. Everybody see my slides?
Yep, clear.
Excellent. So in this 10 minutes, I want to talk about CAR T cells. And even though the focus of interest here, and quite appropriately, is on solid tumors, I'm going to focus on blood cancers because, as all of you know, that's where CAR T works right now, and just show you one maybe small piece of data at the end relating to solid tumors. Here are my disclosures, none of which are relevant to this talk. So don't have to tell anybody in this group that CAR T cells in ALL, which is what we treat in pediatrics most frequently, are very effective, seeing anywhere from 82 to 97% CR rates and 5-year duration of remissions without further therapy, including transplant, around the 45 to 50% range. So that difference between potentially 97% and potentially 50% is due to relapse and not due to toxicity, especially in pediatrics. And that relapse has two mechanisms, and this sort of gets into the resistance questions for us today. So you can get patients who you're targeting CD19 and you get CD19 positive relapse, and that's really largely, if not exclusively, largely due to T cell mechanisms. The CAR T cells aren't lasting long enough, and I can talk to you about how that might work. And there's also potential for immune-mediated rejection, but we really don't see that clearly in our data yet. The other mechanism is tumor intrinsic due to antigen escape, and I'll talk about ways to try to prevent that. Single agent doesn't prevent the antigen escape problem in CAR T. So one belongs to the T cell and one belongs to the tumor, fundamentally. So this is the paradigm for T cell development, and this has been looked at in terms of what the appropriate T cell is when you collect it from the patient, which you don't have control over, and when you manufacture it from that collection, which you have some control over. And what you're looking for is not a bunch of these cells toward the larger end of the developmental, when you've got more T cell proliferation, effector memory, terminal effector type cells. You're looking for more of these naive stem central memory and central memory cells, which are the smaller end of the cone here, which are much earlier in T cell development. And these are the cells that have enormous proliferative capacity and the potential for long-term persistence. And in the particular CAR T that we use, we have patients who have persistence out to 10 years. So this is also about half the patients have persistence a year or more. And if you have persistence at 1 year, you probably have persistence at 5 years. So this is long-term persistence. And so we had a chance to sort of study that. And in studying it, this is one approach that we took, doing both bulk RNA-seq and single-cell RNA-seq analysis. And you can see the clustering analysis showing that you can find these individual T cell populations by deconvoluting their RNA expression patterns in the UMAP plot. And we're able to look at these different T cell populations and ask the questions in this clinical trial setting where we see long-term persistence, and we say, hey, what really gets us to that long-term persistence and what doesn't, talking about resistance. And fundamentally what you see, and this is now in patients who do or do not have 6 months worth of persistence, which seems to be a key dividing point for leukemia CAR T. May not be true for lymphoma CAR T. I want to be very clear about that. This is in leukemia, where persistence seems to matter a lot more. And so you see these naive stem central memory and central memory cells, and there are way more of these cells in the product than in the patients who have long-term persistence and the patients who don't, suggesting that having more of these cells in the product is beneficial to this long-term persistence phenotype. Whereas if you have more of the effector memory cells, you're going to see a lower likelihood of that long-term persistence. And all of these differences are statistically significant. So the effector T cells are great in the short term. They do a lot of work in the beginning, but they aren't around for long enough to really provide sterilizing tumor control in these leukemia patients. And so these cells, as they live fast and die young, so you see more T cell proliferation in these later T cell types, and you see more apoptosis in these later T cell types. So they're proliferating, they're killing, they're going away, and they're not there long enough fundamentally for the effect. And this is getting the right T cells is a big part of resistance or non-resistance to CAR T therapy, and will remain important in solid tumors, even though the targeting and trafficking problems are the big deal in solid tumors. And so one way to go after the issue of antigen loss, which is the other mechanism of resistance, is to use bispecific T cells and CAR T cells. And the Stanford group and many others, including our group, have been looking at CD19 and CD22. And CD22 is an excellent second target in ALL, with 90% of the cells expressing CD22, even after CD19 antigen loss after CAR T cell therapy. And so in the short term, the approach used by the Stanford group showed excellent responses. So at least there's not an interference between 19 and 22 and getting the responses that you want. In this particular study, the responses were relatively short-lived, and so it hasn't quite solved the problem yet. But I think this may get back to the appropriate T cell type before manufacturing and after manufacturing, and that needs to be studied in more detail. Now, the group at Penn that we work with, led by Noel Fry, also looked at two products, one targeting CD22 and one targeting CD19, and very interesting kinetics. You can see the CD19 product peak first, and you get a little bit of toxicity from that. And toxicity was completely manageable in these patients, but they were relatively low tumor burden. And then a later toxicity related to the CAR22. So the two cells do have different cellular kinetics, and you can discern that in the blood, but you can also discern that clinically in the patient. But excellent response rates, excellent durability for the length of time reported at ASH, and there's been one patient with a molecular recurrence, and these days, of course, everybody's responding to these molecular recurrence, but 10 out of 11 patients were evaluable with ongoing CR/CRi. So that looks somewhat promising, but again, we have to look at the resistance patterns and the relapse patterns. And then I'll offer you one piece of solid tumor data, one of the only few instances where we've seen an engineered T cell have significant responses in a solid tumor. And of course, this is the NY-ESO in synovial sarcoma data. And if you look at this top group of CT scans, you see this circle tumor. Interestingly, a couple days later, it gets bigger. Oh my God, it's not working. And this turns out to be pseudoprogression. And you can actually see in panel D that you can find these T cells both in the tumor and in the pleural fluid in this particular patient. So there is some trafficking. Now, remember, this is a TCR and not a CAR. And then you go out 4 weeks, you go out 12 weeks, you go out to 9 months actually in this patient, and you can see response. Now, does this mean that there is a potential improvement in outcome if you're using engineered TCRs instead of using CARs in T cells? Well, this N of 1 doesn't really tell us the answer to that question, but it's going to be extremely important to try to understand that going forward. And with that, I'll turn it over to the next speaker. Thank you very much.
I had a little trouble finding the spot.